So we continue our endeavor to get you biggest voices as far as the COVID-19 situation in India is concerned. And today we're being joined by eminent Professor Shamika Ravi. She is well-renowned in her field. You must have all heard about her. She's been doing some exemplary research on the COVID-19 situation in India. Thanks very much, Professor, for taking time out. I want to first begin by asking you, Professor, how do you read the current situation? India has already crossed the 4 lakh mark. Where are we today at the moment when you compare us to other countries in Asia as well as Europe, which reported high number of cases in the initial few days?
I would say that clearly, while we have flattened the curve, if you consider the delaying in the peak, which is the basic objective behind large national policies, stringent policies of the nature of lockdowns. And we have been now, we've had 4 consecutive rounds of lockdowns. And naturally, as is expected, over the last months, we have seen that the growth rate of the total number of cases have been declining. So overall, while the growth has been declining, we have not yet peaked, which means that with every consecutive lockdown, and of course we've had violations, but that apart, every consecutive lockdown, the nature of stringency has only reduced. So, and as is expected and as should be in a large federal country like ours, a lot more essential items, a lot more movement has happened. And so over time, you're seeing that the numbers have been increasing. And now the infection has spread, I think, to almost all states of the country. But despite that, I think what remains a cause of concern truly is the fact that almost 2/3 to 70% of the new cases are still coming from the big hotspots of Maharashtra, Delhi, and Tamil Nadu. Which seems to suggest that while the overall infection has spread, our biggest causes of concern still remain the 3 hotspots. And I think that is why, in some sense, you can say that while the infection still is very much concentrated in the 3 hotspots, somewhere we also need to do a lot more within these 3 places to bring the overall infection to a control. But overall, of course, the growth has been slowing. Some states have done remarkably well. Some states are still struggling. And as should be expected for a country the size of a continent. So we are really talking about sort of a European experience all put into one. We have our own Italies, we have our own Germanys. And that's the right sort of spirit and the right way to look at the data.
Okay. Ma'am, with every passing day, we're seeing a peak or a new high as far as, positive cases is concerned. It crosses 10,000, 15,000, 14,000 mark every single day. Now, many people are saying that's because India is testing more than what it was doing, let's say, in the beginning of this month or the last month. Are you of the same opinion in that the number of cases are rising because India is testing more, or is the infection also spreading at a faster rate, perhaps?
Well, there are 2 things, I think, which should be highlighted and made very clear so people don't panic. One is, yes, we are testing a lot. In fact, we've seen an exponential growth in terms of the total number of tests per million. But at the same time, we're also seeing that the positivity rate, which means how many confirmed cases are there per 100 tests, that has also gradually been increasing. So now that is around 6%. And it used to be around 4% if you look at the numbers in April. So clearly there has been an increase in the infection itself. That's number 1. And number 2, while the overall numbers are increasing, Shweta, what is increasing very, very rapidly are the recovery numbers. So it's important to convey the message that most people, majority, are actually recovering and recovering rather fast. So naturally, I think while you look at the overall numbers and there is cause of concern, I truly think we should be observing the active numbers much more closely. Because you see recovery, and this is a global phenomenon, people are recovering. It's not as lethal or fatal as it was initially thought to be. And this is also reflected in terms of the death rate per million numbers. And while in India it is remarkably low still, it's around 10 deaths per million people. Consider Belgium with almost 900, close to 850 deaths. Or if you look at Western European countries like Spain and France, which have very, very large numbers, 600, 650, etc. 10 is a very low number. So I think the fatality of it should be also put into perspective, that we have almost 1/10 or lesser the number of fatalities as most major European countries which have been hotspots. But still the infection is growing. And if you look at the the antibody testing beyond the PCRs, which is usually what we are looking at a day-to-day basis, because we don't have as many other than the ICMR large study that was conducted. We do know that the prevalence of the infection is much more than what the PCRs are picking up. So these are really multiple pieces of a large puzzle. The PCR tests give you one picture. The antibody tests give you yet another picture. But clearly, it seems to suggest that the infection is a lot more common than what we perceived initially, and it's a lot less fatal. It's a lot less lethal than what people perceive it to be, and therefore the panic, I think, is to some extent quite unfounded, and we should convey that to people.
Right. I think that's quite an interesting line. A lot more prevalent and a lot less lethal. I think that should put to rest a lot of concerns around COVID-19. One important piece of the puzzle, and I think you briefly touched upon it, is the fact that the mortality rate in India is different when you compare it to the other countries in Europe. And, there have been articles written on this very topic by the BBC and other international organizations as to why people dying in India are a lot lesser than the number of people dying in other parts of the country. What do you attribute this, the difference to?
Well, frankly, we'll need so much more research than the current existing knowledge we have on the virulence of the pandemic itself. That could it be that the strand that we are seeing in India is different from the one that was observed in, let's say, China, or the ones that were observed in Western Europe or the US, because there the mortality numbers are a lot higher. There is reason to believe that our strand perhaps could be different. Of course, the initial research that came out also conveyed that the temperature and humidity are contributing factors. Then another contributing factor could just be the age. The demographic of India is it's a lot younger country. We are a lot younger than the OECD countries, which were the initial hotspots. And all of these, and of course, now the comorbidities are a large contributor. So as the German data that we studied, it was very evident, and subsequently we'll be dating it every few weeks as the data has become available, which is individual level data. It is very clear that the mortality is much higher for men than for women. And this is consistent for every age category, right? So in every age category, you are seeing many more men die of COVID than women. And the gap in the mortality between men and women is also widening over time, which means it is becoming more lethal for men compared to women for every age category. Now, it's important to be able to do some of this analysis for India. When we do state level analysis, let alone national, while they are interesting and they are important to get an overall sense of the pandemic, it's not terribly useful as far as policy prescriptions or policy recommendations are concerned. And that's why, if you recall, right from March, when we started to do some of this analysis, we have been requesting the different government institutions to make the contact tracing data available, to make a lot more testing data available for us, or even just the patient life cycle. For instance, when he said 80% people globally don't need any intervention, right? Don't need any hospitalization or intervention, they recover on their own. How relevant is that for India? So for instance, of all our people who are tested positive, how many end up in the hospital? And for those that do end up in the hospital, how many subsequently require ICU or ventilator or oxygen support? These are empirical questions. And these can vary country to country. These most likely do vary from country to country because comorbidities are different, age profiles are different. The nature of the infection itself could be very different. And in India, I'm absolutely sure that it does vary state to state. Now, we have started to look at Karnataka data because data has been made available, and I'm extremely happy about that. So there is a group of scholars across the country. We've come together and we are analyzing that. We want to also estimate the infection, in terms of the reproduction rate. So Germany estimates its reproduction rate, the R0, every day. So we are in a position to say a lot more about Germany today, Shweta, unfortunately, than we are in a position to talk about, place where we live. And I think that ought to change sooner the better. But I think
are you
one
getting
other
the help that you
contributing
need from the government
factor
as far as research is concerned? Since you talked about research, and are you getting the help that you need from the government? Is enough empirical research happening in the country as we speak?
No, there's very little empirical research. I think we are flying blind. I think we should not, fool ourselves. Of course, this is a large pandemic, all hands on deck. Everyone ought to be fighting, in terms of actual treatment and sort of reducing the spread. But that is where the health infrastructure and the health workers and the entire public and private health apparatus ought to be put to work. But there is a very large group, people like us, people who are data scientists and people who are empiricists, who are in a position to contribute if we have the right data, to be able to say that, look, a reproduction rate is also not uniform for a state or even for a district. By now, we know from having analyzed data across the world, so we've looked at Japanese data, we've looked at German data, and we do know that, infectiousness is not uniform. In fact, the SARS experience of the past has shown us that, majority of people, 80% people don't infect someone else. It's usually, in fact, the SARS experience showed us that it was really just 6% of overall cases that eventually spread to a majority of people. So you have concepts of super spreaders, which is extremely, this concept is very important. And we have to therefore put together the contact tracing data to then identify this dispersion in infectiousness, that what is the location, what are the specific conditions where the spread is a lot higher, and where are the other places where the infection has not spread. So for instance, when we talk of Dharavi, or we talked about the Nizamuddin episode in the beginning, similar contexts exist in many other parts of the country, right? Yet we have not seen that nature of outbreak there. So these are therefore empirical. We really have to study the contact tracing data to then identify that, can we say now, these are the identifiers for super spreaders. Therefore, policy ought to be designed to really curtail and contain, those cases, rather than large national level or even state level lockdowns, which are extremely harmful, for the economy as a whole. And I think livelihood, mental health, this is a very stringent measure. I think fine tuning of the policy to contain this virus eventually rests on our knowledge of the virus. And that knowledge will eventually only come from the data.
Okay. And you're saying that more empirical research perhaps is needed in India at the moment to get better, to equip ourselves with more and better knowledge about COVID-19. I want to also ask about testing, Professor. You briefly touched upon testing and you said we can't really rely on one form of testing over the other. Are you happy with the way India is testing at the moment? We are touching approximately 3 lakh tests per day, if my memory serves me right. Are you happy with that number?
Well, I'm happy that it has grown so much. Of course, one important factor is that there is nothing called too much testing, because the more you test, the more knowledge you have. Now, for instance, currently we have a confirmed positive rate, which can tell you that, of every 100 tests, how many are confirmed positive COVID cases. That is about 6% in the country. That's pretty high. We should try and bring it down to below 2%. Right? Now, when, again, at a national level, we're talking about this massive country, a place like Delhi has 16.2%. Maharashtra has close to 17.5%. Those are very high numbers, right? Which is telling you that, a very large part of the population there is infected. And as we are testing more and more positive cases are coming to the fore, which is obviously telling us that we are chasing the virus rather than being ahead of it. So if the positivity rate is high and continues to grow, that just tells us that testing is extremely inadequate, right? At the same time, you have tests, states which have really brought down this infection rate. And that's where you have to look at Andhra Pradesh You have to look at states like Rajasthan, UP, in fact, even Assam, Jharkhand. Many states have truly over time just ramped up testing so much that overall, the positive confirmed cases to 100, which is in some sense a measure of the infection rate in the general population, has been coming down, as it should be. So again, we have to talk about states, and I think national level stats really, don't tell us that much. But it's a good thing that we are testing, and I think we need to fine tune it a lot further and bring down this positivity rate.
Right. Right. Professor, a lot of, district magistrates I've been speaking to, a lot of healthcare officials I've been speaking to are telling me that we're not reaching the peak yet. We're not at the peak yet. In fact, ICMR is also continuously saying we are yet to reach the peak. When are you expecting that peak in your assessment?
We have as many peaks as states and union territories in this country. And I think, again, at that point, it's important to then sort of try and understand whether that peak can even be sustained, given the nature of, the flow of people between states. So let me tell you that the peak, the way I define it, is, when the total number sort of stops growing. So it's really it plateaus at the total number. But the peak is really in terms of the active number of cases, which means beyond a point, the active cases don't grow. They stagnate and then they begin to fall. Right? Which means recoveries then begin to increase and new cases begin to fall. Right? That is the, sort of the definition of peak. Now, if you start looking at the Delhi data, since, let's say, around 15th of June, we are seeing some structural breaks in Delhi. Now, over the last almost a week, Delhi is reporting larger and larger recovery numbers, and of course, larger number of deaths, which means that active cases are actually falling. So current growth rate of active numbers in Delhi is around minus 3.4. So when active numbers are falling, we have seen a peak in Delhi, right? Now, but you still have to understand that peak with the point that the active numbers are not zero. You're still seeing around 3,000 new cases daily. So a peak is, it's one peak. You're going to see waves. It's important to also appreciate the fact that in a lot richer societies, countries, with a lot more government capacity, a lot more research and healthcare capacity, like Germany, like Japan, like South Korea, seeing second wave. In fact, Germany currently, our analysis shows that has the highest R0 they have ever had. Okay. Right? Which and because one fine morning they discovered more than 650 cases in a particular locality. So a peak does not mean that the virus will go away. A peak is just telling you that in terms of active number of cases, you have seen a very large number and now recovery is much faster. Okay. But Iran has shown that after seeing a peak, now they're seeing a second peak, which is almost twice as high as the first peak. So resurgence happens. And I think till we see a vaccine, and a vaccine which is very widely available to people, I think every country, and particularly us, who are a resource poor country with very limited health infrastructure, I think, the sins of the fathers, so to say, over the last many decades, the investments that we have not made in healthcare is staring us in the face, and it's a reality we have to live with. We should not live in any illusion that the virus will go away. So a peak, yes, we will see peak. We will see peaks in our different states. I think state governments are going to struggle in bringing down these numbers. But whether we will eradicate this virus, I don't think we should, bet on that.
Okay. Before I let you go, Professor, just one last question, and I think a lot of us are thinking about this right now. When are we expecting a medicine, in layman's term, or a vaccine? There have been developments in India as well as abroad. What is the most promising development that you've heard in last couple of days that makes you be a little more hopeful about how things are going to turn around in coming few months?
Well, I think it won't just be the availability of the vaccine, Shweta. There will be sort of a larger geopolitical mobilizing around the availability of the vaccine. So from it being ready and undergoing a randomized control trial to be tested for its efficacy, from that stage to becoming available in, let's say, a village in Chhattisgarh or Patna, will take years. And I think that is where it's promising that there are entities, private entities as well in India, who are gearing up and sort of getting into alliances and collaborations with several, big pharma and sort of testing labs globally to try and create the capacity that once a drug has been discovered, a vaccine, we are in a position to then sort of produce it here at scale and at cost, which can then be available for. But at the moment, there are several trials. We have had some disappointments as well when we felt something was effective and it was proven not to be. So we'll see. I mean, this is the trial and error stage of, I think, the development of the vaccine, the drug itself. But as we know that it usually takes years for vaccine to be developed against a virus. And in this case, the development we have seen over the last few months are showing, and the way forces are joining together to make this available to fight this common global sort of threat. I'm a lot more hopeful that we should be able to, develop something a lot quicker than we have in the past ever managed to do for any other pandemic. So I'm hopeful, and at the same time, I'm glad that you have forums such as these, which sort of translates the numbers to common people and tells them that, look, this is not like there's a lion walking outside and it'll get us all, and it's not as fatal as it is made out to be. And eventually, a lot of it will depend on our own innate immunity. So I think just taking care of yourself and maintaining the social distance, the physical distance, the mask. I think masks have proven to be, amongst all the limited studies we have, to be the most effective non-pharmaceutical intervention to fight this battle. So I think we'll all continue to do our own bit.
Absolutely. Professor Ravi, thanks very much for your time. I'm hopeful that I'll be able to speak to you once again, perhaps when things become better next month. Thanks very much for taking time out. Thank you.